Good afternoon, ladies and gentlemen. I started 5-6 minutes late on purpose so that all the people trying to find this auditorium will actually hopefully get here. Thank you very much for coming. I hope you're going to enjoy this symposium entitled Challenges Facing Global Surgery. Global surgery is going through quite a rapid turn of events at the moment. And we've asked 4 eminent speakers to give us their opinions on various aspects of global surgery. I know them all personally. They're all extremely good speakers. And I'm sure that you're going to enjoy the session as much as I. So I start, if I may, by asking Dr. Walter Johnson to come up and start us off. He is going to tell us about the role of WHO in global surgery. Walt has been, for the last year or so, lead as far as surgical care is concerned at WHO. And his main role, as I think he'll probably tell you, is implementing the resolution that went through. So, Walt, over to you, sir.
Thank you. Well, it's really a privilege to be here, and thank you, Bob, for the kind invitation. My background is neurosurgery. I think I'm the only neurosurgeon here, but anyway, I think you'll suffer through this with me. Let's see, there we go. Surgery at the WHO, it started in 1980 with a speech by then Director General Hafton Mahler he put global surgery in the context of a social justice issue, and it has remained that at WHO to date. The era of only the best for the few and nothing for the many is drawing to a close. That was 1980. That was 36 years ago. Since that time, we've kind of had a hiatus because of vaccine programs kind of eclipsed whatever surgery was doing. The HIV/AIDS crisis of the 80s eclipsed surgery. And the third thing was surgery is really diluted because it's cross-cutting across every domain at the WHO pretty much. We went in the 80s and 90s trying to prove that surgery was good. We talked about dailies averted, and we talked about cost effectiveness, comparing surgery to the treatment of infantile diarrhea and things like that. Surgeons didn't know dailies from anything. It's a public health term. But we tried to couch this in terms of these things to prove that we were doing good. One thing we knew was that the demand for surgery was going up as the entire world shifted from communicable to non-communicable diseases. Populations were getting older, and the so-called diseases of prosperity were taking over. And you can see things in orange and red down here, all communicable diseases, getting less, and all of these require more and more surgical care. 2004, the Emergency and Essential Surgical Care Program was begun by Dr. Mina Cherian, an anesthesiologist who retired last year. In 2005, a global initiative for emergency and essential surgical care was started. It's a global forum for people to communicate, blog, talk to each other. We have meetings every other year. We have now almost 2,200 members in 140 countries. Surgical Care at the District Hospital is a manual on surgical care designed specifically for rural situations and the integrated management of emergency and essential surgical care. Toolkit is on a CD, and it covers everything from posters you can put next to your scrub sinks and disaster care manuals, tool instrument lists, etc., and the situation analysis tool, which is a data sheet on each institution. From the Surgical Care at the District manual that was put into a 5-module course that could be used using PowerPoint. It can be downloaded from our website and is used for training purposes, primarily for district hospitals. But there is, in the US, we talk about death by PowerPoint, and so we converted that into an e-learning platform that has embedded videos. It has pre and post module quizzes, so you can keep track of how your students are doing. And this should be downloadable fairly soon. But 2015 was a banner year. There was 4 things that happened in rapid succession within about a month or 2 of each other. And I will not talk too much about the DCP3 or the Lancet Commission, since Andy will be speaking next. But I will talk about WHO and the United Nations side of things. The UN put out the Sustainable Development Goals last spring. Number 3 has to do with health. And the previous Millennium Development Goals had about 3 things that were related to surgery, either directly or indirectly. This has 8. There are 8 things on here that have direct relationship to surgical care or to the resolution, which includes finances, etc. The last World Health Assembly, which is our governing body, they tell us what to do or what is important. The World Health Assembly is made up of every Minister of Health on the planet that comes together every May and discusses health issues on a global scale. And they passed the resolution 68.15, strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. So let me tell you a little bit about this resolution. There's about half of it is things that are urged on member states, and the other half is things that are directed towards the Secretariat, which is me, because Margaret Chan doesn't really get involved with surgical care. If you look at all of the components of the resolution, they really, if you kind of distill them down to their essence, there's 5 things. It has to do with advocacy and resource development. It has to do with access to care, system integration, so the patients in the front lines can get referred quickly and seamlessly to higher and higher levels of care. It has to do with data collection and analysis and using that data to drive health policy in the country. It has to do with essential medicines and then surgical workforce, who to train, how to train them, how to credential them, how to monitor and evaluate them so that what they're doing in their population is actually making the population healthier. And then we have to report back next year on our progress. So we've had a series of meetings at WHO. This was the Global Initiative meeting, the 6th biennial, that was held at the World Headquarters. And there was 150 people that came for the very first time ever. I was not the only neurosurgeon there. We had 7. But this is our group. And basically we had breakout sessions where we looked at each of the components of the resolution and figured out a roadmap to implementation of the resolution. And we came up with a printed roadmap. We also came up with a timeline over 5 years on the global scale, a regional scale, and a country scale. And probably the most important thing, other than focusing our minds on milestones, was a list of partners that we have. You see a few question marks there, but who are our partners? One person, myself, sitting in an office in Geneva, can't do very much on a global scale, so we need to have partners to actually accomplish these goals. And some of the key partners, this is certainly not exhaustive, but lists several of the partners: surgical colleges for training and credentialing, things that surgical colleges, professional societies do very, very well. Essential medicines is taken over by the World Federation of Societies of Anesthesiology. They love medicines and things like that. Lancet Commission is helping us with data collection and so on. So as I mentioned, there's some key recommendations: advocacy, promoting awareness and whatnot of the issues of global surgery and access to care, reducing barriers, and then developing dashboards for ministries of health. So there's a number of things that we do for advocacy. One is we use social media. I'm learning how to do it. I'm a very late adapter, but I'm learning, and these are just a couple of the things we use. Social media. Another is to go to meetings such as this one and talk about global surgery. Even though I know I'm preaching to the choir, that's not always the case. This was a conference in Cambodia. One day was about global surgery. The next day was about global neurosurgery. And so I had an opportunity to go to both. But I've been probably to a meeting a week for about the last 2 months. All parts of the world, from India to Cambodia to Chicago and other places. This is a Lancet Commission slide that I stole from them, but it has to do with access, and I use this slide to demonstrate the issues with access to care that most people in the world do not have. Information management. Peter Drucker said you can't manage what you don't measure. I went to the school that Peter Drucker founded in Claremont, California, so I'm a big fan of Peter Drucker's. And what you can't manage what you don't measure, and you can't improve what you don't measure. And we all want to do much better. So last year, the WHO, if you look at all the numbers of health indicators that are out there, there's probably, it's on the order of 800 or 900. And that's if you go to a country and say you need to capture these 800 or 900 indicators for health, their eyes glaze over because they really haven't been collecting data on anything. So last year, the WHO published the 100 core indicators that they felt was the very essence of, you couldn't get lower than this. This is what countries needed to target. And if you look at health systems, there are several surgical indicators embedded in there. Postoperative mortality rate, surgical volume, 2-hour access, surgeon, anesthetist, and obstetrician density, catastrophic and impoverishing expenditure. Those are the 6 that the Lancet Commission also highlighted as key surgical indicators, or core surgical indicators. They were also added to the health workforce accounts. And then I guess in March, World Bank published 4 of them as, for the first time, as World Development Indicators. You can see surgical volume, SAO density, and then expenditures. Postoperative mortality rate is really hard to collect, and as is 2-hour access. And why is all this important? Why is all this data collection important? Because between the World Bank, WHO, and others, we can leverage countries into saying, well, you start collecting this data, and you can tie it into development aid, you can tie it into all sorts of ways to encourage countries to do this and actually improve the health of their populations. And then we want to help with the data to create so-called dashboards that ministries of health or others can look at and very quickly tell what's going on in their country. Most of us who are surgeons are visual learners. I don't know about ministries of health, but these dashboards are really helpful. Essential medicines, there's really 3 topics in essential medicines. First is ketamine. There's a country on the planet that's trying to bring ketamine into international scheduling, which would mean that everything has to have an import license. It's a scheduled, it's a controlled drug. So organizations such as ICRC or MSF would have to get import licenses to bring ketamine into a country where there's a disaster. MSF uses about 50,000 vials just in Syria alone per month. It would be a disaster. And in Africa, where 70–80% of emergencies are done with ketamine, it would pretty much dry up and there'd be no more ketamine. So we put on a big hard fight last October and kept it from international scheduling, but it's an ongoing fight because it's a street drug in many countries. In the US, we call it vitamin K or special K. And So it's a problem, but it should be dealt with on a country-by-country basis, not with international scheduling. Narcotics, 80% of the narcotics in the world is used in 6 countries. None of them are in sub-Saharan Africa. And then antibiotics, the antimicrobial resistance is an issue that will be important to every surgeon. Training and credentialing, we have many partners with Royal Colleges, with COSEXA, WACS, any professional society that wants to be a partner with WHO, we are welcome to that. We, with the group in Sweden, put out the Global Surgical Workforce, which is surgeons, anesthetists, and obstetricians, and we're adding the neurosurgical workforce to this summer. The plastic surgeons are collecting their data, the orthopedic surgeons are interested, and we can all put this on this interactive global map. So what is the role of WHO in global surgery? It's taken me a while to get to this point, but it was the title of my talk. This was published in 2010 by Steve Bickler and David Spiegel, and it's kind of a cartoon of where WHO should be with all these different agencies. I think it's a pretty good idea, but the main point is that what we do is really targeted at the country level. The people that we work for are the individual countries. There's some work we do on a regional basis, a little bit on a global basis, but our real target is countries. We have several ways of interacting with professional societies, NGOs, government agencies. There are things like collaborative centers. We're developing collaborative centers. Right now we have 2, one in Mongolia and one at the University of Western Ontario in Canada. They bring specific expertise to the WHO, and it's a special relationship that is contracted and everything. We're also wanting to develop one in Lund based on surgical workforce issues. One in Bogota, we've been invited to have one there based on neurotrauma. There's some very famous people working on neurotrauma there. Mumbai on just general trauma. Dr. Emmanuel Mikasa wants to develop one in Africa, in Zambia. And then there's some interest in having one on injuries and burns in Beirut. We're also getting away from just having WHO and collaborative centers just by themselves. What we really want to do is establish networks of collaborative centers so that everyone can talk to each other and thrive in that environment. We also have what's called official working relations that several NGOs have, the WFSA, the World Federation of Neurosurgery Societies, plastic surgeons, SICOT, the Orthopedic and Trauma Society, all have official working relations with WHO, which is a nice technicality, but it actually allows them to come have a seat at the table for World Health Assembly and other official events. So since this conference is about challenges, I thought I would bring up a few of the challenges. If you look just at the specifics of the resolution, advocacy. I mean, I'm one person sitting in an office in Geneva trying to be an advocate for surgical care and anesthesia. It's really hard to do it. We don't have a global fund such as HIV, AIDS, malaria, and TB. We don't have funding really of any type. We don't have famous champions. We don't have Sir Elton John getting up saying we need more money for AIDS, etc. And we have a lot to advocate for. I've been in this position since August, so it's kind of new. But funding is number one. We can't get anywhere without funding, without advocacy, without getting some big voices bringing awareness to the issues of global surgery. access to care, there are immense barriers, the time, capacity, safety, affordability, even in the US where we supposedly have such good health care. I've had patients that just didn't have the right insurance and their metastatic tumor grew back in their brain bigger than it was to begin with because they had no access to chemotherapy or radiation. The inadequate, inefficient systems, you have places on the planet where there is no system, all the way to places that I can't mention that are bureaucracies and very difficult to get anything done because the system is so rigid and petrified. Data collection. Most countries in the world don't know how to collect data. They don't know, there's no, we call it a culture of data collection. We'd like to develop, countries to invest, just like they are investing in training physicians, invest in training data collectors. People in public health love that stuff. I don't think surgeons will be out there collecting data. It's hard enough, I get my residents to fill out my operative reports because I don't want to waste time doing it. But that's part of data collection. We all need to be part of it. Essential medicines, these issues with narcotics, getting narcotics available to adults and children in Africa is going to take a lot of work. Keeping ketamine from international scheduling, the issue of antimicrobial resistance, all these issues are ongoing. There's not something that we're going to solve and then it will not come back anymore. They're all going to be ongoing issues. The issues of training, credentialing, oversight, the severe shortage of professional caregivers and surgeons, anesthetists, and obstetrician, it's a huge issue. Who do we train? How do we train them? How can we be innovative? Could we have disruptive innovation? I think WHO is uniquely situated where we can establish core curricula and international standards, if you will, for training and oversight. In the US, we have what's called boot camps, where we'll bring in junior residents for 3 or 4 days and just show them the essentials of what they need to know in a variety of situations. But to my view, I think that we have an opportunity. There's incredible hope right now. Just a year ago, we barely were learning about Lancet Commission, the DCP3, the Sustainable Development Goals. We didn't have a resolution. And suddenly all these things are on the table. We have all this data, we have all this information, and we were not there just a year ago. So I think it's time for incredible hope. It's really, what we're doing is at its infancy. There's unprecedented momentum. Every time I give a talk, there's a line of people, generally young people, wanting to talk to me. How can I be an intern? How can I be involved? I get emails from people, LinkedIn invitations from people wanting to be involved with global surgery. Countries are interested. Countries will want to improve the surgical care. They're looking at this data and saying, we need help. Can you help us do this? So there's unprecedented enthusiasm from countries. And I think it's, when there's data that shows you how bad the situation in the world, it's a wonderful opportunity to seize the opportunity and carry this whole thing forward. There's WHO is very interested in collaboration, very interested in developing partnerships of maybe even yet unthought of ways. And I think it's truly a time for us to unify our voices. We're all wanting to push the agenda of global surgery, and it's time to come together and just get the job done. Thank you very much.
Thank you very much indeed, Wolf. That was an excellent beginning to this session. Has anybody got any urgent questions they'd like to ask? We're going to have a question session at the end. If there's any burning question to ask Wolf now, while it's fresh in your mind. Okay, we'll wait again. Thank you very much.
Thanks.
Second on the agenda is Andy Lever, who is probably well known to most of you. He is co-chairman of the Lancet Commission on Global Surgery, and he's heavily involved in implementing various aspects, and he's going to give us a little talk on global surgery in 2020, what can be achieved. Andy.
Great. Well, I'm going to say a few of the things that Walt said, but slightly differently. But essentially, I'm going to start off by asking, what is global surgery? And I think global surgery, for me, is an area of study, research, practice, advocacy that's aiming to improve the care, the outcomes of the neglected surgical patient. And there are many neglected surgical patients, people needing anesthetic care in low and middle income countries in particular. And it's also about improving the whole surgical system. It's both a clinical perspective, if you like, and a public health issue. And as Walt's already described, last year was a banner year for global surgery. In that, there were some key publications. There was the resolution passed, the first resolution that it focused just entirely on surgery. There'd been other resolutions focusing on aspects of surgical care, but this was a resolution for surgery. And there was the launch of a global alliance, the G4 Alliance, to promote surgical care and anesthetic care. So that's a lot of activity, and yes, a banner year. But was it a banner year for the neglected surgical patient, for the woman who is in obstructed labor in West Africa, for the young man who's in the mountains of Bolivia who has a fracture, or the child in Burma who has appendicitis? No, it wasn't a banner year. Nothing has changed in 2015, but there's the possibility now, I think, for change. And so the question that I've got to address is, well, what can we expect 4 years, 5 years from now? The Lancet Commission had a focus on 2030. Why 2030? Because generally in development, everyone's thinking about 2030. And so it had a focus on 2030. But what can we expect, a little bit before then, 2020? Now let's just remind us that change happens very slowly. We've already heard about this comment in Mexico City to a group of surgeons, the then Director General of the World Bank, of the WHO, saying, passionately pleading for a focus on surgery. And yet 34 years later, at the inaugural meeting of the Lancet Commission, a very similar comments. And so in 34 years, little had changed. So can we expect there to be significant change over the next few years? Well, I think there is a degree of optimism that there can be change because surgery has gone up in terms of priorities at a global level. I think certainly those of us in the global surgery community would say that's without doubt. I think there are others in the wider global health community that are yet to be convinced. I mean, if you sit down with a group of health advisors from the Department for International Development, it still feels as though you're speaking a different language. And so there are parts of the global health community that are yet to be convinced that surgery is important. It might seem crazy to us here, but that's the reality. And we are surgeons, so it seems strange, but we have to convince people. So how do you convince the lay public? Well, you talk about surgery as being important across the life course. If you're talking to a group of clinicians, you talk about surgery being important in every disease burden. If you're talking to public health colleagues, you might best say, well, surgery is important across all levels of care. So there is this ongoing need because surgery has not been on the global health agenda. It's been part of various MDGs, but frankly, if you look at the maternal health MDG, there was very little focus on obstetric surgical care. And therefore, there are thousands of women who are dying for lack of cesarean section. And so it really wasn't on the global health agenda. Is there an opportunity now? I think there is, because of the way the SDGs are framed, because of the fact that the Lancet Commission and DCP, the others, the resolution are raising that profile that I've spoken of. So I think there is opportunity. I'm going to say a little bit about the Lancet Commission, and because I'm not quite sure how much everyone knows. Has it been your bedtime reading in the last year or not? I hope so, but it may not have been. So let's just run over a few slides what was achieved in the Lancet Commission. A commission is there to generate a broad, sustainable improvement in a critical area of global health. The first Lancet Commission was on climate change, the health impact of climate change. There have been a series of commissions since then. This was one on surgery. And we really needed evidence to inform policy. Now, we generated a little bit of evidence, but a lot of it is modeling evidence that informs policy. And so I would say that actually we must not say, well, we've got the evidence now. We've had a Lancet Commission. I think we're at the beginning of a journey. There's a lot of research opportunities, a lot of research that needs to be done with low and middle-income country partners to really produce the evidence at a country level. But that's what we set out to do. And we came up with a set of key messages, 5 of them, some set of recommendations, the indicators that Walt's already referred to, because if we can't track change over a period of time, how do we know that there's improvements? The child health community in global health has done this brilliantly over the last 20 years in terms of tracking change in child mortality, maternal mortality as well. And so we need similar indicators to track improvement in surgical care. And we came up with a set of 6 indicators, sort of high-level indicators, small number. Of course, there were many other indicators that might be important, particularly clinical indicators. But we came up with a group of 6. And then this idea of having a template of a national surgical plan. Because it might seem surprising to you, but only 2 lower middle-income countries have surgery within their national health plan. As I say, it really has been rather neglected. So the message is, firstly, 5 billion people can't access surgery. No, I'm not actually saying they can't access surgery, but can't access safe, affordable, and timely surgical care. The previous estimate was 2 billion based on operating theatre density. This is based also on 3 other dimensions: a proxy for safety, a proxy for timeliness, and a proxy for affordability. So that's what we're saying, 2/3 of the world's population. So we've got a problem, which we're only now, I think, being able to articulate. The Commission came up with this concept, not of a whole list of priority operations, but this concept of a functioning first-level hospital, the district hospital, nearest to the rural communities, or a district hospital serving the urban poor. And that hospital needs to be able to deliver 24/7 what we've described as the bellwether procedures, the laparotomy, the fracture fixation, and the cesarean section. Because our evidence showed that actually if you can do these 3, you're going to do a whole lot of other essential general surgical, obstetric, and orthopedic procedures. And so that's what perhaps is perhaps a simpler way for ministries of health to think about this. Modeled the fact that we need another 143 million operations. It would take a while to unpack that, but I can over tea if you want. And that we clearly need to do something about the surgical workforce. We've come up with this threshold of between 20 and 40 specialist providers. And so if you look at a country like Sierra Leone, where I was just last weekend, there are, from a country of 6 million people, 8 surgeons, 1 obstetrician, and no practicing medical anaesthetist. So we're way off 20 per 100,000. Now, in a country like Sierra Leone, it's far more realistic to also include generalists, so medical officers just out of medical school who are running district hospitals, and also non-physician clinicians. Now, if you add in those, there's about 150 in a country like Sierra Leone. All the anesthesia is done by nurse anaesthetists, and much of the surgery is now done by non-physician clinicians. And Biku Ghosh is going to be talking about this later. Now, it's greatly contested, this. And many of our colleagues in the lower middle income setting, particularly in areas where there is the greatest need, would actually argue against task sharing. And they would be able to back those arguments up. So it's hotly contested. But we clearly need to have a threshold of surgical and anesthetic providers, and we're suggesting it's that figure. The Commission came up with a lot about the economics and the finances of surgery, and the reality is that the poorest pay out of pocket. And they may go, they may not go, but they may go and a diagnosis is made, even of, say, of an acute abdomen, and then they hear what it's going to cost, and they walk away without being able to have care. Or they go through and are pushed into impoverishment or catastrophic expenditure. 33 million people a year are pushed into catastrophic expenditure. That's spending, aside from your food, 40% of your annual income on that operation. So 33 million. And if you take indirect costs, it's 81 million. And it's because of the method of payment. And for the poorest, it's not public sector, it's not external funding, it's certainly not private insurance, it's out of pocket. And that is the problem. The Commission came up with a lot on investing in surgery and the sort of finances of surgery, and the argument that actually it is a good investment. The return is good. So if you look at how much it would cost, and this is all model data, how much would it cost to get all countries up to a level of 5,000 operations per 100,000, which we believe is the threshold. 88 countries are way off that. How much would it cost to get those 88 countries up to that level between now and 2030? And it's 350 billion US dollars. But if you don't bother, the macroeconomic hit is 12.3 trillion, up to 2% of GDP. And so it's quite a powerful argument when you sit down with a Minister of Finance and make that argument. And that's beginning to happen. And so the policy solutions, or some of them from the Commission, were that there clearly needs to be a scale-up of donor and domestic funding. And it's not all development assistance for aid. Development assistance for health, rather, it is a small part of health finance. There needs to be a scale-up of donor funding. We need to track age to surgery and track domestic funding. At the moment, it's very difficult to see what's going into surgery. And most importantly, we need to adopt a pool coverage that includes surgery. There's a lot of talk about universal health coverage at the moment. What is universal health coverage? Well, different people will say different things, but for me, it's ensuring that the most essential operations, there's pre-pooled payments for. And so we don't have a situation where women are dying in obstructed labor because they can't get their cesarean section because they can't afford it, or the same for some of these other essential procedures. Surgery is an indispensable part of healthcare, and the argument that I think's been made is that, without strong surgical system, and we're really talking about a surgical system, you need a strong health system. Without a strong health system, you can't reach universal health coverage, you're not going to reach your sustainable development goals, end poverty, or individual global health communities like the cancer community aren't going to be able to reach their targets. It's really important. The indicators I'll come on to in a moment. There are a set of 6. 2, how prepared is the surgical system? 2, what's the quality in terms of volume, but also quality of care? And 2, related to the finance. And then this idea of this national surgical plan. And every country is going to be different. And so it's a template for ministries to sort of pick up and run with. So what can we achieve between now and 2020? I mean, we've heard about the WHO. We need funding for the WHO to be able to play its part. That's absolutely crucial. We're going to hear about trainees from Caris in a moment. We can say a lot about trainees, but I'm actually going to focus on these 3 issues. Independent accountability, national implementation, and the G4 Alliance. Now, what do I mean by independent accountability? Well, it's something that I learned from this man, Richard Horton. He didn't give us a lot of guidance about how to do a commission, other than the fact that you've got to come up with some metrics and clear messages. And the only other bit of guidance was this issue of independent accountability. I think governments need to be held accountable. And one way of doing that is actually tracking improvements in surgical systems in every country over time. And so this idea of a group of independent academics, if you like, publishing regularly, every 18 months, 2 years, what's happening? For every country, what is the workforce at now? How many operations per 100,000 are being done? What's the perioperative mortality, et cetera, is the idea. And so that's something that is doable. In fact, my fellow co-chairs are going to be sitting down with Walt next week. We're going to be talking about this because we very much want to support the WHO in this role. And these, as I say, are the metrics. Can they be collected? Yes, they can. They can. There's papers that are just beginning to come out to demonstrate it can be done. And I really want to turn to Zambia as a great example of leadership here, because they have been able to track 5 out of 6 of those Lancet metrics. They've been able to demonstrate the fact that 75% of their population live within 2-hour driving distance of a hospital. Now, that's, of course, not close enough. We need to make sure that those that those hospitals are actually 24/7 being able to deliver surgical and anaesthetic care. But it's really just touching on the geographical metric of, can you get to the facility? It doesn't touch on the first delay of whether you think about going to get care or whether you're put off because of the financial hit. But that's one of the metrics they've collected. They've actually got evidence on all their surgeons, anaesthetists and obstetricians, and it amounts to, in the country of 14 million, so around about 100, it amounts to 1.1 per 100,000. So they've got a long way to go. They've got a long way to go. But actually, Zambia is one of those countries that has prioritized task sharing and this concept of clinical officers. And so the real numbers of surgical providers is slightly higher. And they now know how many operations are being done across the NGO, private for-profit, and government sector. And it's way off the target. And so actually, in Zambia, I think the met need is 26%. So still, 3/4 of patients who need urgent care don't get it. In Sierra Leone, it's 90%. But that's a start. I'm going to say a little bit now, in the last few minutes, about national implementation. What do we mean by this? This is what is important. It's about ministries of health, with some help, because sometimes that's needed, to actually begin to move forward. And so we had a meeting last few weeks in Dubai where different ministries of health, India, Madagascar, Zambia, and other countries coming together to learn from each other. Hey, surgery is important. How are we beginning to prioritize surgery? And so that's a positive thing that's happening. And as I say, there'll be different solutions for different country contexts. One thing that we're advocating is that ministries of health, international institutions, NGO sector, which is really important. In some countries, over 50% or more of surgical care is being delivered by resident NGO hospitals or mobile NGO setups. And so NGOs are important. We need to bring industry in and obviously the clinical leadership coming together. And this is hot off the press. This is Sierra Leone last week. A tremendous meeting where we brought, basically we brought with WHO in-country team working with King's and supporting the Ministry of Health. The Chief Medical Officer seems to be thoroughly engaged. The Director of Hospitals and Labs seems to be thoroughly engaged. The Director of Policy, Planning and Information at the Ministry seems to be engaged. The Chief Nursing Officer seems to be engaged. It seems positive. And importantly, all the stakeholders are there. So as I say, the NGO community, the private sector have an important role to play, and government hospitals, both tertiary and some of the district hospitals represented in some of the remote parts of the country. The academic community also there. And I think this is positive. And what's coming out of this is 4 working groups to focus on key issues, to then begin to help develop appropriate policy at a ministry level. And all of this, yes, needs to attract funding, absolutely. But it's a start of what's probably going to be a 5 or 10 year process, I'm sure. And lastly, the G4 Alliance. The G4 Alliance is a professional advocacy group. And Bob, our chair of this session, is very, very involved in the leadership of the G4 Alliance. And I think there have been some very successful alliances in global health, the Gavi Alliance, the NCD Alliance, but these alliances take time. If you look at NCDs, actually it's taken about 2 or 3 decades for people who have been advocating to prioritize a non-communicable disease on the global health agenda. It's taken that long. And so it's not a given that the progress of last year will continue. The advocacy is really, really important. And I think I'm going to end there. Thank you.
perhaps we'll have any burning question now? Okay, save them up. Again, thank you very much indeed. The third speaker this afternoon is Biku Ghosh, who I've known for many, many years. He's been heavily involved in training non-physician clinicians in undertaking surgery in Ethiopia and elsewhere, and he has a particular vent for that. And I've asked him to speak on the role of trained non-doctor surgeons in addressing the unmet needs of surgery in developing countries. Biku.
Thank you very much, Bob. Thanks very much, Bob, for asking me to come and do this presentation. I'll just go back 10 years. I raised some eyebrows in Edinburgh in ASGBI, and Bob will remember when I talked about surgery as a public health issue and also training of the non-doctors. It's a decade has gone. At that time, many surgeons couldn't believe we are talking in a surgical conference about public health. But now I think more and more people are realizing public health is something which affects everybody's life on a daily basis, and if surgery is dissociated from that, it is not going to help anybody. In that, actually, I raised the same issues which are being talked now, why actually surgery is a public health issue and how surgery can actually help as a public health strategy to reduce mortality, morbidity in the whole of the world. I think we heard from Andy already the unmet needs of surgery, so I'm not going to go into details of that. And for the purpose of this talk, I'm going to stick to not surgery because I know this is a general surgical conference. I'm going to talk about surgery, anesthesia, and obstetrics because you cannot imagine in a rural setting, you'll have one surgeon specializing in doing this, one obstetrician, and a specialist anesthetist. In fact, anesthesia purpose, we know that 102 countries in the world, most of the anesthesia are given by non-doctor anesthetists and very successfully. So we know that prevalence of surgical disease in the whole world is about 11%. And 25% of the deaths can be potentially prevented by timely access to surgery. We already heard the numbers of the 48 low-resource countries. An estimated almost 300 million people are living with a surgically treatable condition. And annually, 5.6 million deaths could be averted by timely access to surgery. And also, to add to that, most of the people affected by the surgical condition, and often trauma is becoming a big problem, are very young adults. As a result, we are losing lives in their very much prime or even before that, and also that has got a huge impact on the country's economy. And to achieve surgical workforce, already we heard from Andy that we need 20 SAI, as we call them, per 100,000, and a scale up is needed. So what's the snapshot? Currently, in the whole world, we have got just over 1 million specialist surgeons, just under 500,000 obstetricians, and just over 500,000 anesthesiologists. However, when you come to low income and low middle income countries, which represent almost half of the world population, they have got only access to 20% of this workforce. In terms of density, low income country has got 0.7 providers per 100,000 compared with up to 56.9 in high income countries. And Africa and Southeast Asia are particularly underserved. And this number does not reflect that most of these places, actual access to the specialist, are affected by factors such as urban-rural distribution, where you live, dynamics of the workforce, and how much money you have got. This is a slide I borrowed from the current COSESCA president who presented in Dublin a couple of weeks back. Now we heard during an earlier talk with my colleague neurosurgeon, during a personal talk, that in the States they have got 3,000 neurosurgeons. In the COSESCA region, that means the East, Central, and South African region, they have got only under 1,700 practicing surgeons. and only half of them are general surgeons. So regional ratio is 0.53 per 100,000 population. And 85% surgeons, they serve the 15% of the urban population, but 85% of the people in this part of the world live in the rural region. For example, in Ethiopia, they have been training surgeons, very small numbers. In 35 years, they trained over 300 surgeons in the country and abroad. But currently, they have got only 245 practicing surgeons. 106 of them in Addis Ababa. 91 has already left the country. So what is the role of non-doctor surgeons? I'll call them NDS. They are variously called non-physician, clinical officers, etc. For this talk, I'll talk about non-doctor surgeons or NDS. Now, at least 30 countries in the world use some sort of task shifting in surgery. That means non-doctors are doing some sort of surgery. They work out of 25 out of 47 sub-Saharan countries, and in there, about major surgeries performed in 7 out of them by non-doctor surgeons. In Tanzania and Mozambique, almost 90% of cesarean section obstetric laparotomies are done by the NDSs themselves. In Malawi, 90% of the CS and district hospitals are done by the non-doctor surgeons. One additional benefit for these non-doctor surgeons, apart from the workforce itself, because their training is not internationally recognized, they are going to stay in the country. They are not going to leave. So what about the training of these non-doctor surgeons, how they are trained? Now, use of non-doctor mid-level health workers to provide specific surgical problem has been widespread in Africa and other developing countries. But that could be sometime training one particular person for doing intensive training for 3 months to learn how to do cesarean section or cataract operation, something similar. But more and more actually, we are talking about proper training structure. And this actually started in Mozambique. When the war torn the country, every surgeon, every physician left the country. They had no choice. And they started in 1984 a 3-year training program focusing on emergency obstetrics and trauma care. And they are also given training in how to do craniotomies, splenectomy, bowel resection, and skin transplants, and also aspects of war surgery. In Ethiopia, in 2009, the integrated emergency surgical officer training was started. I'll talk about that in the next couple of slides. And we heard about Zambia. Now, there's a Costa Africa program through COSESCA, as well as also some of the royal colleges, clinical officer surgical training, which started in Malawi and Zambia, structured training program. Although COSESCA had been building surgical capacity in the 10 of the African countries, they have been not directly involved in actually structured training of the non-doctors for more than these 2 countries, Malawi and Zambia, so far. So what has been happening in Ethiopia? Now, this program started in 2009. This is a master's program, and it is to train the non-doctor mid-level health workers in emergency surgery obstetrics. The strategy was to overcome the human resource scarcity of senior specialists, especially in the rural location. And recruitment was from the trained health officers or BSc nurses who has at least worked for 2 years, and then they go to some entrance exam. Then they're given 3 years training in a master's program. Idea is to produce emergency surgical officer competent to perform emergency surgical, gynecological, and obstetric operation. They started in 2009, initially with 3 universities and 11 hospitals. By 2013, this was expanded to 11 universities and also 33 hospitals. First graduate came out in 2012-13, and by the end of 2015, already 800 has been trained. And future plan is to have 1 ISO per 100,000 population throughout the country. So how are these non-doctor surgeons doing? There have been few studies. For example, in Mozambique, in a study of over 10,000 major procedures done by the technicals, it shows their mortality, morbidity was basically very much acceptable, similar to anybody else. A prospective review from Malawi of the outcome of emergency obstetric procedure by the doctors and the non-doctors showed no significant difference. In Tanzania, obstetric operations done by the NSS and medical officers, there was no significant difference in any of the outcomes. More recently, in Malawi, in Zomba Hospital, there was a study done on outcome of major surgical procedures. Of the total, about 3,000 operations, half of them was done by surgeons. 12.5% was done by the non-doctor surgeons, but surgeon being present assisting them, and almost 40% done by the non-doctor surgeons without surgeon being present in the theater or assisting them. NDSS alone performed quite a lot of surgery, which our trainees will be very much really surprised to see, is things like prostatectomies, 50% prostatectomy, VP shunting, strangulated hernia with bowel dissection. There was no difference in the perioperative outcome of the non-doctor surgeons working alone or being assisted by the surgeons. Outcome of the MSPs done by in Tanzania showed of all cases, almost more than a third were non-obstetric surgery, and NDSS performed more than half of this. Surgical specialists, about a third of them. There was no significant difference in the outcome. So this is, next slide is a bit of hot off the press, and it is, I'm collecting data with the ISOs working in the Ethiopia at the moment, and there is Ethiopian ISO Association, and they are helping me to collect data. So far, we started that from mid-April, and so far, 38 responses has been, I got actually a couple of them yesterday, and this morning, I have not included them because it's too late to actually put them together. Now, total, we got 38 responses. Average age, 30 years. They started qualification 2012. Majority of the responses in this study was from 2015. Between them, these ISOs have worked about 636 months so far. Type of hospitals most are working, primary hospitals. And I think we're hearing earlier on from Andy, the government are putting huge effort. The number of primary hospitals in Ethiopia has almost tripled in the last 12 to 13 years. But who is going to work there? Now, when we ask them about if they have got any other specialist, surgeon or gynecologist in the hospital carrying out surgery, or GPs, as they call the general practitioner, medical doctor, only 1/3 or just over 1/3 of them had anybody else, and most of the time either a surgeon or a gynecologist. In that, primary hospital had even less. Zonal hospital, so-called district hospital, out of 10 zonal hospital responses, only 4 had any surgeon or a gynecologist. 6 had ISOs only working. All the referral hospitals had other surgeons. So what were they doing? We asked them how many cesarean sections they have done since qualification. Now, between them, this 38 has done over 10,125 cesarean sections. We asked them last 3 months, January, February, March, so that we can actually look at that data more carefully, asking them about actually their complication, etc. Now, in that period, between them, they have done over 1,500 cesarean sections. Total neonatal death, 4.2%, maternal death, 0.19%. This is not something we'd like to see, but it is wonderful to understand that these people are coming possibly late stage of the pregnancy, and quite often actually it is something possibly will take time to improve. We asked them also how many laparotomies have they done in these last 3 months. Between them, they have done 504 laparotomies. They had 4 deaths, which is 0.79%. 3 died from sepsis. All 3 had gangrenous bowel, 1 due to small bowel volvulus and 2 others due to large bowel volvulus with perforation and peritonitis. And 1 had multiple visceral injury through a bullet wound. and with a lot of blood loss. We also asked them to list any major complication after cesarean section or laparotomy, including any complication which resulted in the patient staying more than a week in the hospital. There was 2.2% of surgical site infection, 0.19% of wound adhesions, and 1 hospital-acquired pneumonia. All the hospitals, bar one, have regular, some weekly, have got mortality, morbidity review in the hospital. We asked them about what is the major constraint in their job, and over 70% said they don't have proper access to blood transfusion as and when they need. Anesthetic cover, most of them had anesthetic cover, but felt the anesthetic support was not as good or as senior as they would have liked. The places where they had surgeon or a gynecologist working, about 1/3 felt there was some conflict with the surgeon and the gynecologist. Job satisfaction, all of them replied. They had very good comments from the patients and the health authority, and they're actually really very happy. But all of them, 100%, have major concerns about the hostility of the job and their career. What's going to happen? Is this a stopgap? What's going to happen in 5 years' time to us? And all of them wanted further training. So in conclusion, the trained non-doctor surgeons are already making a huge difference in providing essential surgical obstetric care in many countries. Tens of thousands of lives are being saved. When you look into this 800 ISOs, for example, I mentioned in Ethiopia, on average, they are doing over 160 cesarean section and over 50 laparotomies every year. That means 130,000 cesarean section in 1 year and about 40,000 laparotomy every year. If you take of the 40,000 laparotomy, more than 20,000 will be surgical laparotomy. That means over 50 laparotomies will be done today, and over 350 cesarean section will be done today by these non-doctor surgeons, which won't have happened if they are not working, and many of them would have died. Now, there are a lot of studies, a lot of data analysis, a lot of these things going on. I think all these are very important, but I think time has come, and this is also to WHO and Lancet Commission as well, to consider now to implement actually where we can see benefits rather than going on analyzing data, we are seeing data. Now, the data we saw, post-operative mortality, etc., is not going to be ever robust because they work in very rural locations. So if you want to have data, you will get data from the big hospitals and the cities. But time has come to implement so that we can actually improve their capacity to deal with the surgical need. Role of this non-doctor surgeon in providing essential surgery now must be respected and also must be properly recognized. And they also need to be given continuous professional development training, which they all want and which they all need like we all do. And also we need to address the issue of the long-term care aspirations. Thank you.
Thank you very much indeed, Biku. Those are excellent arguments for really needs must. If there's nobody there, then somebody has to do the work. Any urgent questions? Okay, thank you very much, Biku. So finally, I'd like to ask Caris Grimes to come forward. She's not quite sure whether she still is a trainee. She's passed all her exams and is now on a fellowship. But she's been very active as a trainee, so to speak, over the years. And so I've asked her to speak on the role of trainee surgeons in global surgery.
Lovely. Thank you very much, Bob. I can see just by looking around there are some trainees in the room and some probably ex-trainees slightly further on in your career people. So quite a lot of what I'm going to say is fairly generic. So this isn't a time, if you're not a trainee, to go to sleep. Not just yet anyway. So what is the role of surgical trainees in global surgery? And as Bob said, I've recently, well, at the end of last year, CCT'd in colorectal surgery. I'm now doing clinical fellowship. But I've been involved in global surgery over about the last 8 years, and therefore most of what I've been doing in terms of research and teaching and training and various other things has been as a trainee. I think I'm preaching to the converted to say that there's masses to be gained by getting involved in global surgery. You know, if you go overseas and go to some low-income countries, you will see things you will never see in the UK, and you will see presentations of things that you will see in the UK, but in a way that you'll never see them present before or since. So if you go as a learner or as a trainee, there is absolutely masses to be gained. You can go as a teacher or a trainer. Many countries run courses such as the basic surgical skills and various other courses which you can teach on as a surgical trainee and be part of the local faculty. If you are further on as a trainee, you may be wanting to go and do some supervision of local trainees doing simple operations. What I would say is just be a little bit careful because the pathology is slightly different. I remember going abroad to Malawi to teach and train local anaesthetic hernia repairs, and my experience to date of hernia repairs have been in 75-year-old men under a general anaesthetic with a small direct hernia, and then you suddenly find yourself without any diathermy in rural Africa with a large inguinal-scrotal hernia, and you're really hoping you've got your nerve block into the right place. It makes suddenly what you thought was a straightforward operation you could do become an almost impossible operation. So just be a little bit careful about that. There's always places and enthusiasm for people doing lectures and talks, either in your subspecialty area if you're a trainee towards the end of your training. There's often some interest in what's happening in the high-income country setting for subspecialty areas, but also bedside teaching and just more general training for some of the district hospitals. There's loads of research opportunities. You need to often create your own research project, research it well and ensure it's adequately funded, and I'll talk a bit more about that. Global surgery, as Andy has said, most of the data we have has been model data. We have very little primary data, and I would encourage you to therefore to do a research project if you are going abroad. We need both quantitative and qualitative research, quantitative to tell us what is happening and qualitative to say why it's happening. And actually we've got very little in the way of qualitative data in global surgery. Audits are excellent and have been used by institutions, medical students doing audits of surgical issues at certain institutions have then been used to for funding applications to improve care in specific areas. And probably most importantly is the building of relationships and partnerships, both clinical and academic, as a trainee. There are do's and don'ts if you're going abroad at any level of your career, and these are all examples that I have come across, and these are the things that you shouldn't do. So do what you want and not what is needed is a problem throughout aid in any area. Is that people want to give for certain things and don't necessarily want to meet the need that is required locally. Fail to engage or partner with local staff, and that's particularly true of some surgical mission trips I've heard, where they go in, they do their own thing, they stay, they socialise with each other, and then they leave. And similarly, leaving behind all your complications. And you may never be aware of all the complications that have occurred as a result of all your wonderful operating, but they may be there. Similarly, you need to do audit and feedback to get an idea of what's happening, especially after you leave. Use all the anaesthetic and equipment supplies. Again, this was a result of a surgical mission that I heard of. And they used all the anaesthetic equipment supplies in the hospital, but also diverted staff and resources away from their other usual tasks, so the normal operating list didn't run for a week or so. Fail to understand and therefore respect local culture and language. Take on procedures you would not be allowed to do in the UK, and that's particularly important if you're a trainee. Going abroad to a low-income country is not an opportunity to start doing all sorts of things that nobody would allow you to do unsupervised here. Because of some of these issues, in fact, because of all of these issues, I got together with the then presidents of West African College of Surgeons, the WACS, and COSEXA, the College of Surgeons, East Central and Southern Africa, and we put together some guidelines for UK surgeons travelling to low-income countries. And they're quite a sort of obvious, I think, some set of guidelines telling you what to do. And I'm pleased to say they've been endorsed quite widely globally, including Wax and Cosexa, the Royal Colleges of Surgeons of Ireland and Edinburgh, the Royal Australasian College of Surgeons. I've still not managed to get formal endorsement by my own college in England, and the American College of Surgeons. Were enthusiastic but not yet officially endorsed. Operation Hernia have also endorsed these. And I'm just going to, Bob wanted me just to run through quickly what these are. They are available on the website. I've not seen actually whether they are available in hard copy on the stall outside, but I'll just give you some bullet points really. Choose appropriate placements. You know, where are your skills? What can you do? What can you not do? Choose something you can do. Work in existing programs. Often there's a lot of stuff already ongoing. Find out what's already going on there, wherever it is you want to go, and work within the programs already happening. That also improves sustainability. Be responsive to local needs. We've already discussed not just doing what you want to do, but actually do what's needed. An emphasis on training of local providers. Now, as a trainee, that sometimes means, and it's really hard, you go abroad, you see a really interesting patient come in, you want to get in and do the operation, and you've got a local trainee and a consultant supervisor, and it means that you just have to take a step back and accept you're going to do no operating for that operation. You'll cut a suture or two, but it's really important that the local trainees take priority at the operating table. You need to be adequately supervised, and I've mentioned that before, but it's also important that your supervisor is actually going to be present when you need them to be present if you're in the middle of nowhere. You need to monitor your outcomes. You need to look at the impact of the institution and look at what is what you're doing sustainable. Regular trips to the same institution over a number of years helps capacity building. What Eldred Parry, who set up THET, often talks about it being health tourism, where surgeons or other medical disciplines go from one different country to another different country each year in order to see the world, but that doesn't really help relationship building or capacity building in a single country. It's much better if you can go to the same place. I really encourage you to do research projects, to build partnerships and academic partnerships. Don't do any project without a low-income country collaborator. Many journals now won't publish research of low-income countries unless there's a low-income country author on it. Do appropriate projects and check what is going to be realistic. Often the data in many places isn't that great, and you have to be wary of that when you're setting up your research ideas. You often have to get local research ethics committee approval, and that can take some time, some months to get that all through the system and get it passed. Don't forget confidentiality and informed consent, including the use of photographs of patients and of operations to use in the talks that you want to give when you get back. UK considerations, there's OOP-E's, time out for experience, or OOP-T's, time out for training. You'll need to speak to your deanery early. They'll need a few months' notice. You need to plan it well in advance. You may need to get medical registration with the country you want to visit. Indemnity, the MPS sometimes issue, in fact I think they do issue certificates for while you're abroad. Research, I've said, you'll need to prepare in advance. And if you are a trainee who is interested in global surgery, then do go and join GASUC, which is a new and very enthusiastic bunch of well-organised anaesthetic surgery and obstetric trainees at that website. So in summary, there's loads of roles: teaching, doing research, audit. There's lots to gain, both personally and professionally, and you've got lots to give too. But if you're going to do it properly, and leave behind well cared for patients, good relationships with your host colleagues and with your host institutions. Leave behind a good reputation both for yourself and the organisation or institution that you represent. And leave behind realistic plans for future collaboration and partnerships. Thank you.
Thank you very much, Caris. I think could all the four speakers come up to the Yeah. Just one thing to say about registration is if you're going to go abroad as a trainee or an established consultant for a long period of time, say a year or more, my advice is don't forget to maintain your GMC registration in this country, in the UK. If you come back and you're not registered, it can take quite a long time. You suddenly find that you can't practice. So well, I hope you agree those were, I'm not just saying because it's me, but I think they were 4 excellent presentations. And I'd like now to open the floor for any questions. Any questions, please? Yes. Well, would you like to? Oh, no, Andy?
I mean, I see, I mean, Walt can correct me, but the GISC is a network of individuals, I think, supporting one another, coming together occasionally. I think that's quite different from a group of not just academics, but a group that came together to write a report that hopefully has helped to position surgery on the global health agenda. And to an extent, the work of that group is complete, although there needs to be a bit of clarity on that because some things are still under the banner of the Lancet Commission, and I think we do need a bit of clarity about that. I think my own view, personal view, and it's that I think we should follow up on the metrics and work with the WHO and publish regularly. I think that should come under the remit of the Commission. I'm not convinced that national implementation should necessarily come under the banner of the Lancet Commission, although individual governments want it to, in some cases. But I think we've got to think quite quickly and carefully through that issue. I don't personally, and I am a member of G4, I don't personally think national implementation should be the work of the G4. National implementation should be up to governments. The high-income country community, hopefully, may play a small role. But I think what we really got to avoid in the global surgery movement is a sense of elitism. And I think really now the ball is in the court of the lower middle income country partners. Many of whom were involved who are involved in GISC and who are involved in G4 and who were commissioners on the commission. But I think now that aspect of global surgery, national implementation, is up to individual governments. But in terms of the global community of players, I think there are quite distinctive roles. I think we should stick with what we're good at. Academics should stick with academic production. Professional advocacy folk should stick with the advocacy work. So I think there are slightly different roles.
Well, would you like to just comment as well? It's relevant to you.
From my perspective, I think that the WHO role is probably evolving. The Lancet Commission did a great job. They came together, produced the Lancet Commission on Global Surgery, which was fantastic. But they're limited in how much they can do. I mean, Andy can't go to every country on the globe and help them with their national surgical care plan, but he's created a wonderful model that countries can follow. WHO's role is still evolving. It's a public health institution that I think there's 3 surgeons in the whole place. How surgery is implemented there, I'm still figuring it out. It's a bureaucracy. It's a bit of a straitjacket approach to anything. I have my hands tied behind my back sometimes. But I think each of those groups that you spoke about have a distinct role. I think G4 has a possibility, if they will seize the moment, to be advocates for surgery. Lancet Commission, as I said, and each one of the commissioners has a distinct role. Lars is working on the health workforce. Andy's working in Sierra Leone. So, I mean, it is new, and I think it will evolve, and I think there's roles for each of us to do, and we need to be creative. But I think the bottom line is that we're all working together. There's none of us that are trying to be superior to the other, and you know, I'm king of the hill and I'm planting the flag. I haven't run across that yet. Maybe I'm naive, but we're all working together. We all want to push the agenda forward.
Can I just come in and say do one other thing? And it's a really, really important question you've asked. And I think someone like Jeremy Schiffman, who is a political scientist who has commented on other global health movements over the last few decades, and he wrote a very good piece in the Lancet a few years ago on the maternal health group. And he has a framework for how things become priorities. And one of the things that in that paper that he argues persuasively about is policy cohesion and the community, you know, sticking together. And I think it's really important. We are a small community. Frankly, even within the surgical community, I mean, this room's not packed. You know, they're in another part of the conference. So actually, global surgery, there needs to be a paradigm shift even within our own surgical community in the UK or in West Africa, wherever. So we're small, and we need to stick together to really make an impression. So it's really critically important we get on.
I think it's worth saying that there are many folk, many organisations, institutions, groups, etc., who would like to assist countries to implement the resolution. And I think if that is going to happen, then it might be a good idea, for instance, for WHO through WALT, to act as a coordinator and a collaborator, if you like, so that he knows what is going on where. Otherwise, you get this great load of people going to the same, or different countries doing the same thing and no collaboration at all. I think we have discussed this, Walt, but I mean, I think that the role of the WHO is not so much to dish out money, but to be a coordinator, so that at least you know what's happening in A, B, and C. Do you agree?
I do. As I said, it's still evolving. I think we have to keep that conversation going. I don't want to be a policeman telling people what they can and can't do, and maybe the conductor of the symphony might be a way to put it. I think there's different models that we could look at on how to do that. I personally think that WHO needs more than one person. First of all, it needs funding. Once the funding's there, then we can put together a team, and then we can devise how we're going to carry that forward. But I'm excited at the possibilities, and I think there's a number of different ways we can push the agenda, but it starts with funding and with talking to each other.
Sure. Any other questions? Sorry, I can't quite see. Yes, sorry.
Certainly, I mean, the fully trained consultant surgeons tend to be city-based, and that's for lots of reasons. I mean, I think any of us who are fully trained surgeons would want our kids to go to nice schools and a bit of private practice, and wouldn't really want to be stuck out in the bush with limited resources. So training people who are already there and who are living locally makes sense, but there's a limit to, I would say, there's a limit to what we can expect them to be able to do. And therefore the emphasis certainly for training of non-doctor surgeons has got to be just basic basic skills and also knowing which patients to transfer up to the higher centres.
I don't think I would fully agree with that, because quite often the distance between the rural hospitals and just to stabilize them and send somewhere is not an option. A non-doctor surgeon should be trained properly and so that they can deal with adequately. And one of the advantages, as I said, with non-doctor surgeons' qualifications are not internationally recognized, at least so far. As a result, they don't move. They may move within the country, and actually where they are deployed depends on their own country's government. So the country government, you saw my presentation, there are zonal hospitals, district level hospitals, where there is no specialist surgeons. So their non-doctor surgeons are actually the only surgeons. But basically they are deployed to the primary hospitals. So primary hospitals, and the earlier on mentioned, where actually the bellwether procedures should be carried out. And they actually must be trained properly. It should not be somewhere you and I would like to have the best possible care, and why shouldn't that be possible for a person living in a village in Ethiopia or Zambia or Sierra Leone? When they come to hospitals, they don't care about what you're called Mr. Doctor or whatever. They want to know somebody who can do the procedure safely and they can survive from that. That's the most important thing.
Well, thank you very much. I think time has beaten us, I'm afraid. So on your behalf, I'd like to thank all four speakers very much indeed for an excellent session. It really was. Thank you very much.